Dr. Gul Bano.
Thank you very much for asking me to present my talk to Pakistan Endocrine Society. It's echoing too much. Right. So, like I said, late effects is fairly new clinics, and we have established it about 10 to 11 years ago when a lot of children were surviving cancer treatment. So, where are these patients seen? Now they are seen in dedicated late effects clinic, which are mainly led by endocrinologists. The criteria for referral to a late effects clinic is they should be in remission for 2 years. They are managed jointly by oncologists and endocrinologists for 5 years, and up to the age of 14 years, they are in a pediatric endocrine clinic, 15 to 17 in transition clinic, and 18 years or above in adult endocrine clinic. So why a late effects clinic and why endocrinologists? We know that cancer treatment results in a lot of long-term effects, and children are more susceptible than adults. And it is estimated that 1 in 500 adults is a childhood cancer survivor. What is really interesting that endocrine disorders constitute 50% of the prevalence of these problems. So endocrine problems can occur acutely during initial treatment, or they can present quite later on as late effects. Particularly those patients who have undergone radiotherapy, the side effects or the cancer-related effects, treatment-related effects may happen several years after the treatment. So in fact, these patients are for lifelong surveillance. In research in the past 20 to 30 years has mainly focused on describing prevalence and risk factors. Some of the new late effects are still being described, and I was one of the fortunate ones. We described hepatic adenomatosis in these patients, and depending on lack of growth hormone and estrogen interaction. So the risk of development of late effects critically depends on the treatment which is being used. And details of these treatments are used to predict what kind of side effects an individual is going to have. I follow UK the Cancer Childhood Survival Guidelines, and these are therapy-based long-term follow-up. It's really important to have an interdisciplinary care because specialists from other fields are required to sort out the problem, early diagnosis and treatment. These are the therapy guidelines, which are these are like a manual of drugs which cause side effects and how to manage them and what to look for. So the treatments that can lead to late effects include surgery, chemotherapy, radiotherapy, and also stem cell transplant. Radiotherapy not only causes the problems with the late effects, but it also increases the chances of secondary malignant neoplasm. And this is because of the chromosomal damage, radiation exposure. So there are 3 important factors when you're looking at the risk factors for the late effects. One is the tumor related. It depends on whether it is a solid tumor in one area or a generalized hematological malignancy. And then there are types of treatment. It can be, most important is chemoradiotherapy, stem cell transplant. But bearing if you use more than 2 treatments together, chances of late effects are much higher. It is also patient related. It depends on the sex of the patient because the problems are going to be different in females compared to male, the age at which they were diagnosed and the developmental stage. And also the length of time since diagnosis and treatment. Family history and genetics also plays a very important role. The second cancer, they have those children who survive childhood are at a high risk of developing second cancers. Certain genetic syndromes or patterns increase their frequency, like Cowden syndrome, like VHL. So regular screening tests are required to check for a second cancer. Now, I'm just going to put on, but if the initial tumor is retinoblastoma, they are going to develop pineal or germ cell tumors. Hodgkin disease, later on acute myeloid leukemia, bilateral Wilms tumor, renal cell carcinoma. And if you look at the treatments they receive, radiation, alkylating agents, and combination of chemo and radiotherapy. Again, underlying conditions like neurofibromatosis, Down syndrome, immune deficiency increases the risk of late effects. And again, family history of cancers. So let's restrict to endocrine system. If you look at the endocrine system, whole endocrine system is affected by both radio and chemotherapy. It's not only the hormonal part of it, but it also results in metabolic effects like diabetes and obesity and bone complications. The radiotherapy constitutes the main risk factor. It causes hormonal dysfunction and also neoplasm in the irradiated glands. This diagram is actually it describes the whole endocrine system. The darker areas in the diagram describe which treatment causes higher chances of late effects. And if you look at it, pituitary, thyroid, and gonads are mainly affected by radiotherapy compared to chemotherapy. So the prevalence of endocrine complications in childhood cancer survivors has been very well worked out. All kinds of endocrine dysfunction happen, but the most common is growth hormone deficiency and primary hypothyroidism. Growth hormone deficiency more common in males and primary hypothyroidism more common in females. So hypothalamic pituitary axis dysfunction is very common in these patients. And deficiencies of hormones vary from mild to life-threatening. It also depends on the mechanism and extent of damage. More acutely they develop, more serious they are. If the tumor involves brain surgery, then the symptoms and insufficiency go on to develop straight away as an acute complication. But following radiation, non-specific symptoms develop for a long time, and then they manifest as a proper dysfunction. So it's really important to listen to patients whenever they report a potential symptom. Do test for hypothalamic pituitary axis. Growth hormone deficiency is very common, anterior pituitary hormone deficiency in these patients. It can be directly from pituitary tumors, or it can be radiotherapy, any kind of radiotherapy more than 18 gray, or a single total body irradiation in a dose of 10 gray, or fractionated of more than 12 can result in growth hormone deficiency. The good news is some of these can recover over time. So the diagnosis of growth hormone deficiency in childhood involves, first of all, is to assess the height of children every 6 to 12 months. And secondly, please do a proper testing for growth hormone. Nobody should rely on just doing an IGF-1 and then say whether it's growth hormone deficient, because there are so many other confounding factors. If patient has got more than 3 anterior pituitary deficiency hormones, then you may escape without doing a formal test. But in this country, we still need to do, because growth hormone is expensive, you need to have a clear-cut demarcation that patient is growth hormone deficient. Then a lifelong periodic clinical assessment is required in these patients. Sometimes these patients may pass what we call as the threshold of the test, and they may only have neurosecretory dysfunction, and it may manifest at the time of stress. For example, growth hormone secretion at the time of puberty, it may be deficient. So when they start in a childhood, we always stop when they reach their height and then retest them. If you look at the dosage of radiotherapy and growth hormone, smaller the dose, less chances of growth hormone deficiency. Closer to the pituitary, much higher chances of growth hormone deficiency. So anterior pituitary hormone deficiency after cranial radiotherapy, growth hormone is first one. The risk is time, radiation dose, and other hormones may decline, but it is quite variable. There was a very good study published, which is called as a lifetime cohort St. Jude's study. 748 patients diagnosed with childhood cancer who received cranial radiotherapy with a mean age of 34 and observed period of 27 years. About 47% had growth hormone deficiency, followed by gonadotroph deficiencies, TSH deficiency, ACTH deficiency overall is very rare. So what are the recommended treatment? Number one, yes, growth hormone after assessing the safety. It's always, we recommend to wait for 1 year till the person is disease-free before starting growth hormone. If there is a chronic stable disease, for example, we know patient is never going to be disease-free, like optic tumors, optic pathway tumors, we discuss it with the patient and we only stop growth hormone if there is a recurrence of the disease. The growth hormone should not be used in children just for growth purpose who are not growth hormone deficient. So pituitary function assessment is required at regular intervals, particularly in patients who have radiations. And intervals depend on, if it's a high-risk patient, that means if you have cranial irradiation of more than 30 gray, it should be done annually. If it is less than 20 gray, then every 3 yearly. It also depends on the age of the patient. Much more frequent testing is required if they are approaching puberty. Because I said radiation can result in long-term after several years, so these patients will stay lifelong surveillance. What about pituitary neoplasm? Because I did mention radiation is one of the risk factors. Some of the studies, experimental studies, have described pituitary adenomas. Cranial radiation constitutes a major risk factor for development of subsequent CNS tumor, and meningioma is one of them. A lot of our patients have turned back after having radiation with meningioma later on. And the radiation-related meningiomas are fairly aggressive and rapid growing. Several case reports are there showing evidence of pituitary tumors after radiation exposure. And prolactinomas are supposed to be the most common, and 2 or 3 case reports have described pituitary sarcoma in such patients. There is a condition called SMART syndrome. It's an acronym for stroke-like migraine attacks after radiation. It's uncommon, delayed complication of cerebral radiation, usually 20 years after radiation therapy. It is a debilitating disease because a lot of these young patients develop strokes, hemiparesis, and the modality for imaging is an MRI perfusion scan. And what it shows gyriform enhancement with areas of cortical thickening and abnormal vasculature in the brain. What about the thyroid disease and cancer treatment? So, cancer treatment is associated with hypothyroidism, hyperthyroidism, and thyroid cancers. Recently, use of immune check inhibitors can impact thyroid function. If you look at the association of hypothyroidism, all risk factors are moved more towards right. They start at younger age, they peak at younger age, and they are more common in female size. I'm not going to go through the slide, this one. These are the risk factors for hypothyroidism, hyperthyroidism, central. But what is interesting is external radiation of less than 20 gray predisposes to thyroid cancer. And also 131 MIBG therapy, which is used for neuroblastoma, is associated with thyroid neoplasm. And what kind of radiotherapy? Any radiotherapy which involves neck, cervical area, total body radiation can result in thyroid cancers. And if you look at it, if you look at the hazard ratio, for thyroid cancer, it is 9.2, followed by primary hypothyroidism, 6.6. Thyroid nodules are quite common, and threshold to do find that aspiration should be very low because association of papillary thyroid carcinoma and radiation is very well described. So the thyroid cancer as a second primary malignancy is quite high in these patients, following the breast cancer and bone cancer. So how do we monitor? Always ask history for radiation and check their thyroid functions. Should be considered more frequent, but annually. If there is physical examination is very important, particularly that of them. If there is a palpable node, fine needle aspiration should be done to get the diagnosis. So thyroid late effects are very common. It can occur years after the treatment. Irradiation is a prime risk factor, and those patients who are at risk should be monitored Remember, we are using novel anti-cancer therapies like immune check inhibitors. Thyroid dysfunction is quite prevalent, and they should all be checked extremely at regular intervals. What about parathyroid disease? The parathyroid disease is reported as a cancer treatment complication. It is also reported as a late effect in patients. My group here, we published under 5 patients of late effects, and we found out that primary hyperparathyroidism was very common in females with hematological malignancies who received total body irradiation as a single fraction for bone marrow transplant. In these cases, it is usually mild, but they are already osteopenic and it makes their bone health worse. The parathyroid adenomas are usually small and single, and system scans may not be very helpful. And some of them can be monitored, some of them have undergone surgery. Hypoparathyroidism has also been described, obviously after neck surgery, radioiodine treatment, but there is also a high-dose radiotherapy in these patients may result in hypoparathyroidism 5 years after the treatment. Being an adult endocrinologist, one big chunk of these patients is concerned about puberty and fertility, and rightly so, because they are 18 years or above. This diagram depicts why fertility and puberty can be delayed. It is cranial irradiation, it is localized radiotherapy, it is TBI, and it is the gonadotoxicity from chemotherapy. So the presentation can be precocious puberty, early onset of puberty, or delayed puberty. It can also cause oligospermia, azoospermia, and also when these patients, when they come to fertility clinic, they need to be counseled for these things. Now, a lot of counseling happens when they are like children, but at that time they don't understand. And unfortunately here in an adult clinic, we don't have proper counseling for them. In females, it's exactly the same mechanism. And even those females who conceive, it is classified as a high-risk pregnancy because radiation, if they are received or chemotherapy, can compromise blood supply to uterus, and they can have small placenta, oligohydramnios, and everything. So in addition to whatever they get like precocious or delayed puberty. And a lot of them have premature ovarian failure. And these are the drugs which can, I'm not going to read through them. High risk for females, high risk for males, medium risk, and low risk. I think there is a very good article which was published in the European Journal of Endocrinology Review. All of you should read about it, that how these drugs should be monitored and how they should be counseled. What about the bone health? Yes, bone health is an important part of, although here in my hospital, we don't deal directly, but it's a part and parcel of late effects clinic. There are so many factors. One, because they are malnourished, nutrition is compromised, immobility when they are going through the treatment. Secondly, the drugs. And third, most important, late effects, growth hormone deficiency, premature ovarian failure, hypogonadism. All these lead to low bone mineral density. And there is a very good study published that all these patients, even if they receive treatment, their bone mineral densities are much lower compared to what controls we are using. What about metabolic issues? Very, very important. Increased incidence of type 2 diabetes and obesity. This is because of the central effect on the hypothalamus, TBI, peripheral effects on the fat cells, direct effect on the pancreas, mediastinal radiotherapy, effect on the heart and the blood vessels. So every patient should be monitored for type 2 diabetes and obesity. Lifestyle changes, advice, exercise is extremely important. So endocrine side effects depend on sex, age, and pubertal stage. Each cancer therapy can result in distinct endocrinopathies. Obesity and metabolic diseases or late endocrine effects should not be forgotten. The endocrine treatment should be used for standard endocrine indication, not for increasing height in a GIT person who is not growth hormone deficient. Please address issues related to fertility and sexual dysfunction very earlier on. And the most important thing, because they are young children, there should be a very planned and purposeful transition to a multidisciplinary adult care team. I'm going to stop here, and I'm happy to take questions, or we'll put it in the chat. Thank you.
After 1.5 years, she had recurrence of tumor in pituitary again, about 1.3 centimeter. So what would be your opinion regarding the first part of my question, and what would you do in a scenario like what I just described?
Khurshid, that in the growth hormone deficient patient, as you mentioned, who have chemotherapy for some reason, when you see those cured by the treatment, how concerned are you for the recurrence of the carcinoma with the growth hormone treatment? This is the first part of the question.
There was a very good study published, a Swedish study, which categorically showed it does not increase the risk of carcinoma. But if there is a recurrence for any other reason, it should be stopped growth hormone treatment during treatment of active malignancy. So I'm really not concerned those people who are in remission.
After 1.5 years, he had a recurrence of tumor of almost 1.3 centimeter. What would be your opinion in such cases?
I said if it is within 1.5 years of start of treatment and it is 1.3 centimeter and is actively growing, we should not be using growth hormone. So that's why we said it is 2 years after being in remission.
Ma'am, we are very thankful for your talk.